Okay, let's start. In this brief presentation, I will offer you a quick overview about the state of the art about augmented reality to guide the surgical procedure. And furthermore, I will insert some news about what we are doing in the spoke number 9 of the Tuscany Health Ecosystem project. In particular, talking about augmented reality for surgery, we have to take into account that for the surgeon, the dream is to obtain a view as the X-ray view that only Superman has, offering him the possibility to see a piece of glass inside the brain of the patient. In this case, the Superman has a real X-ray view, but spoiler alert, we are not able to offer the surgeon this kind of visualization. What we can do, as showed in 1994 by Professor Grimson at MIT, is to merge with the real view of the patient rendering a virtual representation of the internal anatomy of the patient acquired before the intervention using radiological imaging. And in 2000 and sorry. No. Okay. I will try to show you again later. Okay, in 2019, with my group, we obtained this guide of guidance directly in the surgical room, showing in front of the user the planned trajectory to follow with the surgical scalpel, and unfortunately, the video does not work. In any case, it is important to understand that to obtain this kind of visualization, what we can do is to start with the medical images, and from the images we acquire a 3D representation of the internal anatomy of the patient, and eventually in this kind of information we can insert in a precise geometrical approach cutting lines and information to guide the procedure. And if you are able to offer this information over the patient inside the surgical room, we obtain the result. But to implement this kind of visualization, we have to take into account at least 7 key points. The first 4 key points are related to the source of the real information, and depends if the surgeon look the patient directly with his home view or through an endoscopic camera, for example. What about the source of the virtual data? It depends. The virtual data can be an MRI image, CT image, 3D ultrasound, everything. We have to take into account the tracking modality to obtain the right alignment from every point of view, and furthermore, the registration between the different reference systems that we have in the surgical room. But these 4 key points are important not only for augmented reality visualization, but also with traditional surgical navigator without augmented reality with virtual reality. It is important to align that the registration, the 4th key point, is the most important one, and one of the technology that is able to improve the quality of this alignment is related to the using of intraoperative scanners, in particular, as in this case, using an intraoperative combined-CT scanner. And thanks to the Tuscany Health Ecosystem project, in the Spoke 9, we bought one of these scanners that we are going to test during orthopedic intervention. Furthermore, we have to take a look to the visualization too. Visualization is important because we understood that this kind of virtual X-ray view, an augmented reality X-ray view, often is not useful for the surgeon because the surgeon is not able to perceive in particular the depth. For example, now I will show you an old work done by my group to obtain and to guide the realignment, to guide the realignment, no, questo devo andare su questo, to guide the realignment of bone fragments. And no, non funziona nemmeno questo, ok. Okay, in any case, the take-home message is that the virtual X-ray view is often not so useful. Finally, moving to the display, there are different kind of display. Starting from an eye level, we can use the traditional display used by the surgeon during endoscopic intervention. So in case of an endoscopic intervention, the surgeon can visualize this kind of information directly using the same monitor used to visualize the anatomy through the camera. For this reason, in the Tuscany Health Ecosystem project, we have an activity offering the surgeon performing a traditional intervention using the Da Vinci robot. The Da Vinci robot is a robot to perform robotic laparoscopic intervention in which the surgeon visualizes the real anatomy of the patient through a monitor by means of a camera. And in this case, using the 3D scanner that I showed you before, we are able to offer visualization to the surgeon as the one that you can see on the right. You can see there a phantom of a kidney with the different structures inside the kidney, and you can see also the red trajectory planned before the intervention. So as you can see, we already performed the test on Phantom, and now we are moving to obtain the clinical translation. And given our Gantt chart, before the end of the project, we should be able to perform the first of man. Another approach is the using of a projector to project directly over the patient the planning information, obtaining very interesting results in terms of accuracy. But this approach, there are some cons for this approach, in particular in terms of parallax error in case of hidden anatomy inside the patient. While in general, for every intervention performed by the surgeon with his her hand and under direct view, the using of wearable device seems the best ergonomic approach, and in fact there are a lot of demos and trials, and also clinical trials using, for example, displays like this one, in which the user, the surgeon, can see the real environment through a semi-transparent display, as you can see, and with the possibility to add a virtual information. But using this approach depicted in terms of concept on the left, as you can see, in front of the eye of the user, there is a sort of semi-transparent window, and to obtain the alignment between this information with the real environment is not so easy. And in fact, at the state of the art, there are a lot of solutions to obtain this kind of alignment. But all the methods at the state of the art are not so accurate, and in particular, they are not robust due to the parallax between the position of the eye and the position of the display. And so, even if a perfect calibration is obtained, then if the surgeon moves a bit the display, the guidance information becomes not precise. The other approach is the using of opaque display, traditional VR display, in which in front we can apply external camera to offer the user a real view of the environment. With this approach, even if the surgeon can see the anatomy only through a camera-mediated view, the registration is simpler and with a more accurate, because if you are able to obtain the alignment on the 2D image, this alignment is maintained even if the display in respect to the eye moves. Taking into account pros and cons of both approaches, some years ago we implemented a system, but as you okay, I can show you this video. Okay. So, as I told before, given medical images, the surgeon can virtually see inside the anatomy in the image, and he can plan the intervention. And with the prototype, with the idea that we already developed, we can merge pros and cons of the two kinds of displays. You can see here a video acquired in a simulated environment over a phantom. In this case, the display is semi-transparent. You can see the eyes of the user, and in this modality, we can offer the surgeon additional information like the heartbeat, for example. And given that we cannot guarantee in this modality the perfect alignment, we can switch using an LCD panel that covers the direct view and turning on a couple of cameras to restore the view to the user. So we can switch in this other modality. And in this modality, as you can see, we can precisely show in front of the user the planned trajectory, and even if everything moves due to the natural movement of the head of the surgeon, everything is maintained aligned. And as I said, we already tested everything in the surgical room, but the video at the beginning of my presentation doesn't work. We already evaluated that this kind of approach is very accurate and, as I said, robust. And for this reason, inside the Tuscany Health Ecosystem project, with the company that will present the more details during the workshop that we have in the afternoon about the Spoke 9. So with this company, we are increasing the TRL of our solution, both from an hardware and also from a software point of view, and in particular, our goal is to start guiding another type of intervention, in particular the insertion of the pedicle screw to perform spine surgery. Thanks for your attention, and unfortunately I was able to show only few parts about augmented reality.
Good enough, Vincenzo. Thank you very much. Any questions from the audience? Yes.
Thank you very much for the presentation. I have just a curiosity, basing on your expertise and experience and know-how so far, based on the current data technologies, would it ever been possible to produce this kind of vision real time, I mean, without relying on offline data acquired before, like from previous scan? I mean, I'm scanning right now, and I'm showing you right now what's inside the patient. Would it ever be possible to reach with today's technology without discovering something new?
No. Thanks for your question. The answer is that it depends on the available source of intraoperative imaging. For example, as I showed before, now we are improving the registration using 3D intraoperative combined CT, but the acquisition of an intraoperative combined CT in this case means the acquisition of 720 RX image for each volume. That means that we can acquire just a volume up to 2 for the entire intervention. So in any case, it is not a real-time image. What we can do is to acquire more images in terms of X-ray using, for example, 2D images. And in this case, what we can do, and we are working in this direction, is to use X-ray image to compensate movements during intervention. An alternative is the using of MRI, intraoperative MRI, and there are many studies, many prototypes of surgical instruments, in particular robots, compatible with the MRI, but to insert, but it's unfeasible to think in the medium term to insert in every surgical room an MRI with MRI compatible surgical devices. While another available source of information in real time without any X-ray and very easy to use is the ultrasound. In case of soft tissues, in particular, that can be clearly visualized with the ultrasound, we can integrate this kind of information, both in case of a 2D probe and also in case of a 3D probe. And so my group, but many groups around the world are working on this kind of integration, and there are also some interesting clinical results. Obviously, with the ultrasound, we cannot visualize every kind of the anatomy, and so in conclusion, the conclusion is related to the beginning of my answer. So the answer, we have to select for each kind of intervention the best source of intraoperative information. Thank you.